Welcome to Killer Cure. We're focused on preventing disease before it starts, and that mission aligns perfectly with today's guest. Bill, Liao, and I are here to host the program, and we've brought on a wonderful guest that I've known for many, many years, Tom Davis, who has built and sold the first value-based care health system in the U.S. He's advised private equity and large limited partnerships on billions of healthcare capital, and has a powerful vision for how clinical and financial interests can align to create a healthier, more sustainable system. There's a lot to talk about today, and we're super excited to introduce Tom. Tom, do you want to take a minute and introduce yourself?
Well, how can I beat that introduction? Good Lord. Thanks for having me on, guys. Back in the day, I graduated from a family physician residency in Missouri, and I joined a single specialty practice with 3.5 other just visionary physicians. And about the same time, we got the opportunity to be among the very first signers of the very first value-based care type contract ever offered in the United States through Medicare. Back then it was called Medicare Plus, but now you know it as Medicare Advantage. And basically the model there was Medicare gave our payer a certain amount of money per month to care for every beneficiary that had selected us as their PCP. The payer took a piece out of the top, and then we got the rest. And if that patient's care costs came in under that particular payment, we got to keep the difference. If it came in over, it came out of our pocket. And Bill especially would be amused by this. I am not going to pretend that we saw into the future and knew exactly what it is what we were signing. We signed it, and then after we looked at the financials over time, we had a holy cow moment. What have we gotten ourselves into? So we basically had jumped from fee-for-service into this value-based care world in one swoop, and that kind of having that kind of gun to your head really focuses the mind. 18 years later, we sold the health system that we created to a regional competitor for more money than a family physician should have. And since that time, I've been sharing that expertise with business folks, payers, providers, because during those 18 years, practicing value-based care was wonderful. I feel so fortunate and blessed that I had the experience that so many of my peers want now, but can't. And if you look at the research, what makes physicians productive, especially knowledge worker family physicians, are a sense of autonomy, a sense of expertise, and a sense of service. And I tell you, practicing under these contracts, if they're well designed and well executed, gives you all three. And I have survivor's guilt for having had such a wonderful experience. And that's why I'm doing this, is to try to share that with my peers, to let them know that you can practice in a third-party payer system in a way that is just fantastic.
So I've two things to ask there. One presumes that you have survivor's guilt, as do many of your patients who are under your care. And two, what does PCP mean?
PCP is you know what? That's one of those three-letter that I should have stayed away from. PCP is a primary care physician. It is the bureaucratic notation for the clinician who a patient has selected to be their entry point into the healthcare, their health.
Right. So that would be their general practitioner, or maybe a specialist for a particular condition.
Exactly.
Excellent.
Interestingly, oh, go ahead, Bill. Keep going.
No, I was just saying, pardon my ignorance. I'm unfamiliar with these terms.
Yeah. Well, actually, it'll be really interesting to think about how those positions actually translate into some of the areas and regions that you live in, Bill, with you living in Ireland and other more advanced risk-based models where the countries are taking risk. We'll come back to that in a minute. Tom, just by way of color, I remember part of the journey. I was in part of that journey with you when you got involved with the health system and exited. And I still remember that they had no clue what they were buying either. They literally, in that transaction, it shows kind of the gap between what a health system thinks and what a real effective risk-based model looks like. Because that's what you were, right? Like downstream revenue aligned with specialists, integrated with primary care, and that whole focus. Maybe talk about that for a second, because I think that's still missed today in almost every strategy that we've seen in risk-based modeling.
Well, if this journey has been anything, Todd, it's been a constant exploration of things that I thought I knew, but didn't. Wish everybody go on a journey like that. The current healthcare environment is very much finely honed to fee-for-service. That is what the government up till very recently has been paying. That's the model, meaning that you do something, you get paid for it. That's what fee-for-service is. And so if you look around, everything that you see, these gleaming palaces of healing, everything is supported through the idea of throughput. And the fact of the matter is the value-based care model that we thrived under is the polar opposite of fee-for-service. What works under fee-for-service does not work under value-based care. And so if you wanted to buy a value-based care contract and work with it, you could do very well. But if you just want to buy market share, it's just going to cost you a lot more because our value-based care contracts were worth a lot. So that was the decision that was made in that case. Today, we are in a transformational period that's very much analogous to where the real estate market was in 2007. And value-based care, of one form or another, is going to be the payment model when we come out the other side. And that's one of the reasons for the urgency of looking at systems that promote outcomes and the tools that can assist the providers and the organizations to create those outcomes. Right now, we're on a volume-based system for paying for health care. Coming out the other end, it's going to be all about outcomes. And that is going to look very different. The margins are going to be very different. And the organizations are going to be as different as Sears was and Amazon is.
So I have two questions there. The first is, did you find when you switched to that model and you looked at the numbers that it impacted your ability to diagnose / did better diagnosis result in better profits for you?
Well, at the time, to be fair, one of the ways that the government was and is trying to get the payers to pivot from fee-for-service to value-based care is by subsidizing that second model. So when we got into it, it was very overfunded and the designers were still trying to find their way. So there was plenty of margin to play with as we made that transition. Now, the thought processes of taking care of the patients, it's one thing to take care of somebody within a certain set of strictures. You do the best you can, you advocate aggressively, but in the end, you're limited by the resources that are available. And under value-based care, the person sitting in front of me, well, I had unlimited resources to take care of them. The problem was that much of those resources were mine. If I spent money I didn't have, I would have to get partial reimbursement from a stop-loss insurance product, but in the end, it came out of my pocket. Now, early on, I had several patients that signed over 5 and in one case a 6-figure check back to the payer to cover deficits out of their own account. You want to talk about a teachable moment there. So you're a physician or a clinician and you're staring at this patient across the way who you have worked very hard to get in a position to help. And you find yourself balancing your decision making as far as intervention versus outcomes. And what you find is that you're very transparent with the patient. I'm thinking about this, I'm thinking about this, I'm thinking about this. Patient has some copays, so there's some economic incentive for them, but the real economic incentive is for you. And balancing that gives you a sense of autonomy and a drive to become an expert in whatever it is that you're doing. So I found it much easier to care for my patients because it was me, and that was it. And when our payer tried to institute prior auths and step edits for some things, we turned to them and said, no, we're doing great. We have a great performance. If you institute this on our patients, we're going someplace else. And they dropped it like that. This is the power of being high performing and understanding the model. And it is a model that is coming to the United States by 2030 at the latest by CMS's explicit mandate, but probably as soon as next year. There's going to be some big things coming.
And then the second question I have, which is, it's fantastic everything you just said there. And the second question I have is, you sold that network of providers that you built to a competitor. Did they still operate value-based care or did they change?
Well, I don't know if you've ever gone to a museum and seen a Renoir. I love Renoir.
I have, yes.
Just imagine what it would be like. That's beautiful. And then just take a second and imagine what it would be like if you just took that painting off of the wall and threw it on a bonfire. Just burned it to shreds.
Uh-huh.
That is one analogy that someone could draw from that experience. Because I can't mind read, but a reasonable assumption might be that the folks who bought us were buying market share as opposed to the expertise. And I tell you, we were a multi-specialty group. So that means that it was not just the family physicians and the general internists. It was the cardiologists and the urologists. We were equal partners because that's required by law. Everybody benefited from the performance of the value-based care contract. That is a rare instance that you don't see today. Because under value-based care, the specialists and the procedures that a lot of them do, they're centers of cost. In fee-for-service, they're one of the few places where you can actually generate a positive margin. But in value-based care, they are a center of cost. And one of the revolutionary changes that's going to take place, one of the ways that value-based care is the polar opposite of fee-for-service, is that the influence and the prestige of specialists is going to take a radical change. And that's something that was very difficult for my friends who were specialists to accept. These are people we were used to working with and had great relationships with, and so we brought them in. It was still an enormous challenge getting them into the right mindset. But the general surgical and procedural population out there, they absolutely no clue what's coming, none. And they tend to respond in general in a very defensive way. It's going to be one of the real challenges making this change going forward.
Interesting.
And you advise PE firms, if a PE firm was saying, look, here is a value-based care network that we're about to buy, how would you get them to see that keeping the Renoir is actually going to be more valuable over time than burning the painting for its heat?
Well, let me describe my typical PE engagement before I answer that question. And I've been doing that sector now for like 12 years. They will call me with a question about an acquisition or an expansion or a contract. They will pay me a retainer. They will ask me their questions. I will usually tell them, don't do that for this reason. Rather, consider this. They will nod their head. They won't do it. They won't renew my contract. And then they go on, and very quickly, most of them fail. Very few have been successful. And it's because up until now, the investment community has viewed these types of contracts as cash cows because they've been so overvalued and because CMS has apparently tolerated a certain amount of fraud. All that now is out the window. So it's no longer a revenue play. You can't get one of these contracts and print money. You're going to have to succeed on the basis of outcome. Now, when you present that sort of thing to these PEs and they want to make money as quickly as possible, they want to get in and flip, one of the things you have to tell them is that the revenue cycle for fee-for-service is 45 days, and maybe lower if you have a really good system. The revenue cycle for these value-based care contracts, because of the nature of the calculations and whatnot, they are anywhere from 15 to 21 months. And it takes 3 cycles for anything to settle into anything close to a steady state. So these folks are just not prepared to go into it for the long haul. We did because we had to. But these organizations are so ultra short-term focused, get in, get out, that they are unable to appreciate the value of those networks. And that's a shame because now with AI, I'm affiliated with a fantastic technology that will allow you to X-ray that in a second and show you exactly where your costs are, where your leakage is, and how you can improve. But there's no interest in that right now because the revenue cycles are so long and everybody is so short term. And that is all going to change because Uncle Sam is cutting off the dollars and the industry is going to have to respond.
And of course, by PE, I mean private equity investor firms. What does CMS mean for those of us in Ireland?
Sorry, CMS is Center for Medicare. It's actually CMMS, Center for Medicare and Medicaid Services. Those are the folks, it's the federal government that administer the federal healthcare programs. It's different than Medicare in Australia, so you can't really equivalent the two.
Or
Medicaid, or Ireland, yes. But CMS is the federal government's healthcare funding and regulatory authority.
And for us ignoramuses over here in Europe that occasionally hear things in the news, something about a big, beautiful bill and Medicare, Medicaid, How does that play in?
So Medicaid is a state-run program for folks that can't afford health care coverage, and integrated, most states it's integrated into what's called the healthcare exchange. It's a federally subsidized state program for people who can't afford health care. And right now, what you're seeing in the United States is by 2030, most states are going to have Medicaid consume about a third of their entire general revenue. And these are states now, it's not the federal government, so the states can't print their own money. So when you are running a third of your general revenue funding healthcare, you're no longer a state. You are an insurance company with borders. And so in an attempt to address that, because the states are going to be coming to the federal government to give them more money eventually to try to help with their funding problems, the federal government is trying to put some strictures on Medicaid, which is working restrictions and not letting folks who are not in the country illegally get that. All of those are just the barest edge of what these care costs have done, are doing, and is doing. They're just avoiding the big bad issue, which is healthcare consumes almost a fifth of the national wealth every year. What are we going to do to try to get rid of the parasite before it kills us all?
Two questions there. One, doesn't healthcare also, although it consumes, doesn't it also create wealth because healthier people are more productive? And two, would value-based care work in that setting?
Well, there's two arguments. There's no question that there is a benefit. But right now, the way the system works in the United States, it is a significant net drag on productivity up and down the line because the emphasis is on throughput as opposed to outcomes. So when the emphasis is on getting you in for as much health care as you can, and you know that a certain amount of health care is going to cause more problems, which is going to lead to more health care consumption, well, you're in a situation where the net is a negative. And that is the problem that we're talking about. Japan is a great alternative. They have about 60% of our costs, and you would make an argument for them that it's a net positive. And that's because they have done away with the difference between what care should cost and what care does cost. And under value-based care, the government is going to fund based on what their actuaries say. They're going to fund what care should cost. And then what care does cost is on the payers and the providers, who are the ones that, after all, are the ones that are benefiting from that. And that's the flip in value-based care. That's the theory. And in the United States, there's just no more dollars to be printed. You all are already aware of this. In the U.S., 10 years ago, I counseled primary care physicians, family physicians, on how to transition from an in-office practice to a virtual practice. You could become an independent contractor in telemedicine back in 2015, and you could earn the median family physician income in half the time in your jammies on the beach. And it really wasn't that big of a step. So that was 10 years ago. Over time, even with the pandemic, the specialists that did not have procedures could start to do that. Then the specialists with procedures could come to do that. Now, even the highest paid professionals in the healthcare hierarchy can go outside the system and earn at least an equivalent income without all the downsides and without a lot of effort. And the reason that's happened, gentlemen, is because the government has been trying to bend the cost curve on their healthcare promises for decades. They have allowed the industry to consolidate. They have turned a blind eye to all the collusion that's going on in wage suppression. And what they have done is they have priced themselves out of the market, because the dollar bills are created just like magic. But to get a clinician or to get the resources to deliver care takes time, money, effort, and very rare human capital. All that can no longer be for the value of the dollar bill that is out there. And so we are all migrating out. You go to Dubai, our family lost a urologist because he signed a contract in Dubai for way more money than he was getting with his employer. So that's just one example going forward. The federal government is in a tremendous situation because they have made care promises that they can't afford, and what's worked in the past, printing money, is not going to work. If they renege on their care promises, things become very unstable very quickly. If they keep printing money, it's the same as reneging on their care promises. The only thing that they have left is to try to get somebody else to pay for their care promises, and that's what value-based care is. And that person is me, the provider, backed up by this vast pool of liability dollars that underscores all economic activity around the globe through my stop-loss insurance. That is the tactic that they are going to do. They've been very explicit about what they're going to do, and President Trump tried to accelerate it back in 2017. He failed. Come April of next year, all my sources are telling me something big is going to come from the government about this payment model, and our industry is absolutely not ready. Absolutely not.
Can I double click on something really quickly?
Sure.
I think is important for the worldwide investors that join us, Bill. I think that's one context. I'd also say that the U.S. investors that join us and also the clinicians that join us might all have different perspectives. You said a couple things. One, the federal government, one component, right? That's up here. And we're talking about significant payer reform, which I think has been talked about now for 30 years-ish, right? Like, and you have in the US, you have a federal issue, you have a state level issue, and basically it's almost like we have 50 countries here in the US that each have their own insurance commissioner, each have their own payer model, each have their own model. And you look at like how we break things down at Seed, I talk about my theory of change. My theory of change is catch disease earlier, right? If we can catch disease earlier, which is exactly what you're talking about, be proactive and take risk and use diagnostics and tools and data and algorithms and all the things to kind of lead the care and drive the care, and that's going to drive costs down and all that. So long way to ask I've seen it for 30 years. The pendulum swings one way, pendulum swings back, and the payers are not where the reform comes from. The providers are where it really comes from. So what do you do today to say, okay, we're navigating ahead with something that might happen next year or in 2030? And how does it work federally down to the state level? And then what do you think about, as a provider, maybe three different perspectives: a provider, an investor, and a entrepreneur worldwide that has other issues in all of that? I just think it's complicated.
Actually, it's very straightforward. In the world to come, outcome is going to be king. That's it. That's where you direct your investment dollars. And outcome is going to be king because it must. We just outlined federal government cannot pay for its promises without further diluting the dollar, and the dollar can't be further diluted because it's not paying for the resources that the government needs to deliver on its promises. So the change is going to happen, and no matter what form it takes, and no matter when it is taken, it's going to be far sooner than later. Whatever that looks like, it's going to be outcome that is going to be the payment. That's going to be the coin of the realm. I want everyone at each one of those lessons to do a thought experiment. What would have happened in 2008 if the federal government said, you know what, the real estate industry and the investment bankers, they got themselves into this. We're not going to bail them out. They need to burn. And then we'll see what happens afterwards. Now, I realize that that's a more complex thought process than most people can do, but just imagine that. What would have happened? Well, it would be a tremendously disruptive depression, but it also would have opened up tremendous opportunities. And if you were a person that was so inclined and you wanted to open a small bank, that would have been the time to do it, because people would have needed your services and you could offer it on a great level. So there would have been enormous opportunities in that disaster. Well, going forward, this change is going to happen, Todd. And it's not because I'm asserting it. It's because of the math. The same way the mortgage crisis couldn't be sustained because of the math, this is going to happen. So what's that going to look like on the other end? It's going to be outcome. Your biggest risk is going to be being too early. And although many of my investor clients have told me too early is as bad as being too late, that's not true. Because if you're too early, at least there's the potential for some sort of gain in the future. If you are looking for timing, though, Todd, now is the time. Because the one thing that I have learned is that the person that moves first does the best. And Jeff Bezos will agree with me on that. But do you think I could start a value-based care health system right now and then sell it for $250 million in today's money? There's no way. There's too many parasites, too much restriction or whatnot. The only reason I got into my situation, guys, was because we completely by accident and through no perspicacity of our own got in first. And then we ran with it. That's the only reason. And if we sold in the face of the ACA, which made dramatic cuts, and we just decided to, I'm sorry, the Accountable Care Act, the health care reform, or Obamacare, which is what people thought about. And so we sold into the teeth of that just because it was time. But if we had held on for another 6 or 7 years, then we would be having this conversation on my yacht, because that asset would, and I'm not kidding about that, it literally would have been worth multiple billions of dollars, the system that we created. And instead, I'm here just enjoying myself. So
that's why you keep the Renoir and you don't burn it.
Well,
and
exactly.
I might add to your thought experiment, what would have happened in 2008 if the banks hadn't bailed out? Well, I could very strongly argue that we would all be using Bitcoin right now, because Bitcoin was, the white paper was published October 1st, 2008. And if the whole banking system had been disrupted, it would have taken off a lot quicker, in my view. And I'm not a huge fan. I'm just saying, there's your problem. There's your possible answer.
So let me ask you this, though. Put yourself back into that situation and assume that you knew about Bitcoin, and also assume that you knew the government wasn't going to do anything. Let them burn. Would you have considered buying Bitcoin at that point?
I would have set up a Bitcoin exchange immediately if the banks, like I'm an entrepreneur, right? I would have absolutely taken advantage of that. As it was, when the bailout happened, all of the technical issues with Bitcoin prevented me from doing much in it.
Mm-hmm. Well,
and a little bit of philosophy if you compare it to the dollar. Now, interestingly, right now we're seeing the legislation change where these treasury-backed currencies are coming, and they're going to be legal tender, which means that, contrary to your point about money running out, actually we're likely to see one of the world's biggest dollarization events ever, which, considering how strong the dollar is around the world and how often it's used, that's a pretty big number. And of course, if you expand the resource base of a currency more globally, you strengthen it, even though it may be diluted. So that can change the dynamics of a lot of these things.
In the end, though, you can't buy something with nothing. Even Bitcoin that's limited, and even the treasury coins or the Fed coin or whatever you want it, their value is manipulated. The value of the resources needed to deliver health care cannot be manipulated, because they're hard assets that take a tremendous amount of time to be created. They're very similar to Bitcoin. Bitcoin, you got to mine and mine and mine before you get one. Same thing for a family physician, a surgeon, and even though you can use technology to leverage them, in the end, they are still a limited resource that is needed. And no matter what this new world looks like, it is going to be outcomes that are the key, not throughput.
I 100% agree with you on outcomes. I'm going to push back a bit on you can't buy something with nothing, because that's essentially fiat currency. Once you don't back your currency with anything material, you are in fact virtualizing something. And let's go back to the Renoir for a moment. In one mode, the Renoir is a few pounds of canvas and chemicals that is not even going to heat a room when you burn it. In another context, the Renoir is worth priceless, infinite money. So if you take an original Renoir and you auction it, you're going to get a lot of money for that. If you create a new musical track and it goes viral, that's worth a lot of money. And if it doesn't go viral, it's worth nothing. The way value chains work is far more complex than you have to move atoms around in order to call it real value. Now, outcomes, I agree, are real value, right? Because people will pay for a good outcome. We know this. So that's concrete. What you pay for that outcome with, you could argue fiat currency has nothing to do with atoms anymore.
Well, this is a fascinating conversation, because value is complex, because value is a psychological process. A person believes that something has value, it has value.
But no, it's not just a person who believes, it's a person and another person agree.
Right. It's a network.
Like you and I agree that a Renoir is amazing. If we didn't agree, then to one of us, it's firewood, not very much, and to the other of us, it's amazing.
You're right. It's the network that holds value. The outcome is concrete value. The question is, what do you use to compensate for it? And the question also is, are outcomes gameable? because we got into this situation because I, as a clinician, am very good at gaming any compensation system you put in before me. I'm very good. And so are my peers. And that is why every time the government has tried to adjust its payment model, its costs have gone up because we adapt so quickly. And now it's to the point where they want to get out of the game because they don't have the value to fund it. And so as an investor at any level is looking at what is going to happen, and it's going to happen very quickly with this express transition to value-based care. It's going to be things that support outcome in a cost-effective way. And it's going to start with the people who can pay cash for those outcomes, but it's quickly going to spread to those legal entities who have obligated themselves to pay for it. Because right now, all you're getting is kind of a pantomime of healthcare. And the reason that folks don't realize it is because the information about it is being suppressed increasingly ineffectually. Once the government gets out of paying for the actual cost of care, the folks who can deliver outcomes are going to be king. And I can tell you that having worked with health systems at every level across the country, it ain't them. They can do throughput very good. They can manipulate the fire hose of Medicare dollars that are available to them in exchange for favors and rebates and whatever you want to call it. They can invest in commercial real estate and then pump the valuations way higher than they are. But as far as delivering on outcomes, they cannot do it because they're not designed to. They're designed for throughput. I offer an analogy of the dinosaurs. Value-based care and the circumstances that have led to its adoption is the meteor, these big health systems with their shiny white policies of healing. They are all, they're the dinosaurs. They're extinct. They don't even know it yet. But down on the ground, there are thousands of individual practitioners, small organizations that are sprouting from their value-based care practices. And they can do that because they don't have any of the legacy costs of these large health systems. Those folks look impressive, but a combination of overregulation and the ravages, financial ravages of COVID have left them Potemkin villages. And just like, these huge banks and other organizations that were just gone in a matter of weeks during the great financial crisis, we're seeing it around the edges. A lot of health systems now are going under. The big ones are the ones coming next, and it's going to shock people. Shock.
I agree with that entirely.
Well, and no bailouts coming.
Yeah, interesting. So maybe breaking it down to a couple perspectives. If you're a clinician today, what do? Right? You advise a lot of large groups, private equity, all sorts of things. But if you're just a practicing physician with your head down, seeing patients, what are the next three right things that you should prepare for as this transition happens?
So one, you need to familiarize yourself with the model and how it works. Very few physicians on the primary care side understand that. Two, you have to start exploring your own resources and your own predilection for whether or not you're willing to ride out these changes on your own, or whether you just want to go outside of the system and create a cash pay practice or a direct primary care practice or some other alternative to kind of sit things out until things settle. And then the third thing is your relationship with your patient is an asset. It's a capital asset, because the value in value-based care comes from your therapeutic relationship between the patient and the prime. Even with all of these AI and data extraction technologies we have, it's still them talking to you that's going to give you the information that you're going to need for the government to set your payments correctly. And it's that trusting relationship that will allow you to curate their care, that will allow them to call you before they go to the emergency room. Now, that last one is very speculative, Todd, because we thought that some folks would value the system that we had, and it turned out that it wasn't part of their business plan. And chances are, if you work for a health system, they don't value that relationship. But there is a chance that someone might, and you're going to have this panel of patients that you're close with, and you may be able, as things get disrupted, to do things you could never consider, which include taking yourself and your patient panel to another payer that gets it. And then you'll have a tremendous resource. That's a speculative play, though. Maybe better if you find a value-based care organization that's high-performing. You've educated yourself, you know what to look for, and then create your own panel in their practice instead.
So one other perspective to touch on Bill, before we go on, because those three things are really important. My 82-year-old mom who's on Medicare, right? What does she do? Like the confusion around Medicare Advantage, the programs, and all of the payer kind of nuances state to state and then federally, it's complicated. How do you decomplicate it or uncomplicate it?
That's an excellent question. And the reason for all of that is because most providers, most health systems have their foot in both worlds. They have a foot in fee-for-service and a foot in value-based care. And as such, they don't really know which way they're going. They pay their physicians in some sort of bizarre hybrid way. And that kind of confusion is leaking into the care system. When we were doing it, and Todd, you know well, there was no confusion with us. Our patients knew exactly what was going on because we emphasized the value-based care. So for the individual patients who are in this situation, my strongest recommendation is if you have a good relationship with your PCP, hold on to them. And every time you see them, let them know how valuable they are to you. Buck them up because they need to. But if you don't and you have the resources, it's time to look outside the system for a direct primary care physician who you pay a certain amount every month to be your primary care doctor, and then try to ride out the changes there. It's going to be a very difficult and a very disruptive time. And I tell you, Todd, when you talk to the leaders of these health systems, they agree with the idea that there's forces to transition to value-based care, but their bottom line is it won't happen because it can't happen because the government depends too much on the delivery of health care for political stability. And in 2007, the mortgage industry was right. It couldn't happen. It didn't happen. The question is, in 2025, is there enough innovation and capital in the country left in the country to bail out an industry that's twice as big as the real estate crisis? That's hope, and hope is never a strategy.
Yeah. Two quick questions on that. The first one is, you've mentioned stop-loss insurance. I understand what stop-loss is. I understand what insurance is. I haven't heard the term stop-loss insurance in a medical context before. So it sounds like that might be a piece of infrastructure that value-based care models rely on. Is that true? And what is it?
That's an excellent question. So back in the day when we first signed up for this, there was none of that, at least in the medical business. We were actually putting our personal capital on the line. And then our payer started to offer through their own insurance framework what they called stop-loss insurance, which meant that an individual patient, if you lost more than $100,000 on that patient's care during a calendar year, then you were responsible for the first $100,000. That was a deductible. And then the stop-loss insurance policy would cover 90% of the next $1 million of loss, and then 100% of anything over that. So my maximum out of pocket for any single patient was going to be about $200,000. And that allowed me to assume the care of the really sick patients, because the sicker the patient, the higher the payments. And that allowed me to limit my downside loss so I would have the potential for recovering those losses for those really sick patients if I took care of them long enough. The challenge is that these insurance pools are they themselves reinsured by other reinsurance companies or other liabilities, and they're reinsured. And as you probably well know, every insurance entity basically is insured by every other. It's a giant spider web of liability protection.
Is it a giant Ponzi scheme too, or is it just
No.
Just kidding.
Business. They know it's regulated, but they know exactly how much money they should charge you for your premium next year because of your losses this year. And let me tell you, those premiums, if you have a couple of bad years in a row, they can start eating up your margin, which is why we created our own insurance company to provide ourselves stop loss. And of all the things that we tried, all the things that we created, that was the one that was the most difficult. And we learned a lot about the insurance world and how it works and how everything goes back to Lloyd's of London. It is an important, essential tool for this model. But the thing is that these liability folks, they're businessmen, and they are not going to accept liability unless they get compensated for it. And in essence, the government is going to shift the financial responsibility for that actual cost of care through the payers and providers down to this pool of liability money. They're not going to subsidize that. If you're a provider and you have 3 or 4 years of bad experiences, if you can get insurance at all, it's going to be very expensive, just like if you wrecked your car 4 years in a row. So this is, again, where you go from having essentially unlimited number of dollars from the federal government to a very finite and very costly pool of dollars down here. And it is going to change the economics of healthcare delivery in the United States. And I will also tell you that I have interest from folks at the National Health Service who are also looking at something along these models for a subset of the population as they struggle with their own funding challenges.
That leads to an interesting insight. Presumably, that means that stop-loss insurers have a league table of high-performing physicians.
One more time.
Presumably, stop-loss insurers have an internal league table of high-performing physicians who make less mistakes. I wonder if they'll publish that.
Well, that's interesting. I don't know if they have segregated out to errors. I know for a fact they've segregated out for costs. Back in the day, and we were granted the right to purchase stop-loss insurance from private insurers, and they quite quickly extracted the data that they needed and priced us accordingly, and the prices were actually pretty consistent among the different providers. And then we learned about the databases that were available, again, back in the day when we created our own insurance product.
You're going to get a huge amount of data in those insurers about which physicians lead to the best outcomes for them.
That's right.
And that's valuable perhaps to a patient if they could get access to it, to know, well, like, who's the person who screws up a lot in my area and pays a lot for their insurance versus who's the person who hardly ever claims because they get it right.
It certainly is one piece of the quality data. There's no doubt about that. Certainly you would want to know about that. It is my opinion that as this program becomes mandatory and universal, there's going to be different levels of co-pays and patient engagement for physicians who are higher performing than for physicians that are lower performing to try to further incentivize individual clinicians and systems.
And then that leads me to another question, which is a little philosophical again, but that's my bench, Aside from outcomes first, what are the values of value-based care? What are the next two top values of value-based care?
So it's going to be efficiency and it's going to be patient satisfaction. Those are really the three things. The outcome is how well you do. The efficiency is how much does it cost for you to do that. And the patient satisfaction is how does the patient feel about it. And you have to have all three of those to have a high-performing system. You can have various levels of performance with various levels of performance in those three. But if you're high-performing in those three, not a lot else matters.
Yeah, I think that's very true. I haven't seen those values worn on the sleeve of the industry. And it would seem to me that if you were a patient in your system over there, understanding that those are the top three values of the provider that you might choose, sounds to me like that would be a really useful piece of branding to have associated strongly with value-based care.
Well, that's absolutely true. And when you went to see these value-based care or delivery organizations, you did see that. The larger ones have now been absorbed for reasons that are beyond the scope of this conversation. But even the smaller ones, you see that. But don't make a mistake. The vast majority of healthcare delivery in the United States, they value throughput, ancillary income, and real value. That's what they did. That's what they value. Those are the core values.
You broke up for a second there.
Sorry.
They value throughput. They value
throughput, ancillary revenue streams, and real estate value. Those three things.
Yeah.
And you absolutely see that right now. You can say, Dr. Davis, it's horribly cynical. They're all dedicated. Some of them are religious. No. I see them from the inside out. That's their PR face. What they value is those three things, and their actions reflect that. So if you look at their actions, you can see what their value is. What do? They keep building these huge buildings that are way overvalued. That's a value. They don't do it because they need to. They do it because they value real estate.
You mentioned, Tom, the NHS, and I've traveled all over the world the last couple years, meeting in Japan, NHS, all over the world. Basically, the healthcare system across the world is broken. There's still a sick care system tackling the same things we're tackling in the US. It's just a different payer wrapper. I'm curious, you think about like the NHS, they have VUPA, they have supplemental insurance on top of what's paid for by the government. There's all sorts of programs. And again, they still use reinsurance, which essentially is your stop loss kind of program where you're passing off the risk. It's a worldwide problem. and I know the US often sets the example, what do you think the worldwide movement is in really tracking outcomes? Because I don't think that's done anywhere.
It isn't, and it's because at its heart, almost all the payment models are metric-based care. Basically, it's a kind of a set income followed by additional compensation for meeting population-based metrics. Almost every country has some form of that or another. And it is all the malign influence of the healthcare delivery model of the United States. Just like everything else, or just like most things, where the United States goes, the world follows. And if you were, as again, another thought experiment, to magically create an outcome-based payment model in the United States, I think what you would see is a transformation of that into the other systems, but much more quickly, because these countries have much more control over their healthcare delivery infrastructure. It's not going to be a panacea, but it's going to be an excellent fork in the road for these organizations to take. Because at the end of the day, care is a product that generates its own demand. And that's just the nature of the beast. One of the ways it generates its own demand is because a lot of what we do is harmful. One of my professors said, every time you walk on the nursing home floor, Tom, I want you to imagine yourself as Godzilla and your patients as thousands of fleeing Japanese. And I've always tried to take that to heart, because I can do way more harm with an 80-year-old than I could possibly do good. So that is one of the ways that that healthcare generates its own costs. And so if you take the economic interest out of doing that, because right now we're rewarded for making mistakes because it generates more revenue. And so if you take that one piece, just that one piece out of the equation, you're already going to have a positive impact. Other affecting pieces, then it's going to have more of an impact. It's going to redirect the profit motivation for healthcare interventions in another direction. Drugs that are just heavily used now, that have numbers needed to treat in the 80s, which means that you have to treat 80 people with the drug to get one positive outcome, those things are going to go by the wayside because the side effects and the expense are just not worth the improved outcome. And people aren't going to use it because there's no economic incentive to do it. You start making those changes in the U.S., and these other organizations are going to change. To back up my conclusion, I just point out again to the NHS, who have reached out, folks in England who have reached out to me to explore my ideas for the reasons that they're working with the NHS to do the same thing.
Amazing.
Just on the healthcare interventions list of things, the biggest interventions in order of their invention time that have had, I would say, the most universally positive outcomes would be moving your muscles, vaccines, penicillin, arguably all vaccines, hygiene, and then penicillin, right? Like soap. And if you look historically, those four interventions have saved an enormous number of lives at a relatively low cost, with a per person level of side effects pretty low. The odd death here and there. I mean, it's possible to drown in your sink. What would you say is the next thing? What's number 5? What's going to be the next super cheap, everyone can do it, no big downside intervention after the big 4?
I believe it's going to be socialization.
Mm-hmm.
Hands down. I believe that, and again, this is a belief based on nothing but my own experience, but the atomization of society now is leading to a level of illness that is appreciated, but still far underappreciated. And I believe that promotion of social connection is going to be the next intervention that is really going to drive improved outcomes. I'm working with organizations now that are trying to set up communities to do just that, but there are myriad of other ways you can do that. You can create infrastructure, and you can use the science of influence and persuasion to promote connection. And as we become outcome dependent in our healthcare payment model, that is something that absolutely cannot be ignored, because it's going to be so cost effective to make a positive impact.
Could not agree more. Very, 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 very true. And yet so underappreciated right now. Arguably there's a good benefit in doing a podcast together remotely, because it wouldn't happen otherwise. And yet there isn't the same level of connection, right?
Mm-hmm.
And that level of human to human connection is very important, isn't it? In health outcomes and longevity.
And why is that? Well, it's because there's money to be made by the atomization. And if one was a conspiracy theorist, one would think, well, back in the heyday of fee-for-service medicine, that the agriculture had a lot of incentive to make sick food so the healthcare folks could sell medication and the advertising folks could advertise it. And you could be forgiven if you looked at the cross-pollination of the boards of all across these industries to conclude that. I'm not saying that's the case. I'm just saying that aligned interests are aligned. Now, when you're going to focus on outcome, suddenly you're going to get some stiff competition. And if you have a set of social media accounts, you might just have to pay more for your healthcare coverage because just like if you were a smoker. I mean, that would just one expression. If you live in a zip code that has a high socialization score as measured by like a walkability score, but socialization score, you might just pay less. I mean, these are the types of incentives that are going to change that people can't bend their mind around, and especially people in the industry that are so honed to the next quarter's performance and trying to push throughput of their small number of procedures that actually make them money. Can't conceive of this. And as an aside, I get emails all the time are you interested in getting your master's in healthcare negotiation or healthcare management? And I look at these programs. These are the people that are supposed to run our future. And the curriculum is nothing about this. Nothing. The assumption is everything is just going to keep on doing the way it's going to go. The folks running the systems now have no clue. It's going to be the innovators that make the change, and the people who move first, who recognize powerful tools that push outcomes, those are the ones that are going to do the best.
Amazing.
This speaks to the need then for you to create such a course.
I'll put it on my list.
So that
You need to do it with friends.
exactly. And we're all friends here. One thing that you just said that resonates a lot is that everybody's connected to electronics and all the stuff. And we often talk about the older generation when we talk about healthcare. And if you talk about the younger generation today, that's even more complicated, right? The 20 somethings aren't interacting anymore or as much as they used to. There's no procreation except in certain areas that are socializing. You look at the downward spiral of the population in many countries, I think that's a big issue. And you speak towards socialization. That right there is what's happening in the younger world.
There's going to have to be a balance between using technology to connect folks to healthcare delivery versus avoiding the side effects of such technology. Very much like you balance the car. I mean, if you really want to save 50,000 lives a year, just ban cars. No one can have a car by edict. But cars have some benefits. So what do? Well, you do the best you can. Anti-lock brakes, you put on seat belts, that sort of thing. So you try to balance it. You're going to see the same thing with the technology of connectivity. The older folks are going to be more sensitive to it because they're closer to death. The younger folks maybe not so much, but still there's going to have to be a balance, and if things are paid based on outcome, those balance is going to be enforced by the same financial incentives that getting a ticket for not wearing your seatbelt represent.
Absolutely. Well, we've hit on an hour. I want to actually touch on just a few rapid fire questions, Tom, just to kind of bring it home here. And, one question is, what do the health systems do? What do they do today that one change that should be done to prepare for any of this?
It is to accept what is happening on a leadership level and then carve out resources to start doing strategic planning on the assumption that this pivot to payment models is going to happen far sooner and far more quickly than anticipated. That would be the one thing. A lot of them are dabbling in these value-based care contracts. These arrangements come and go. They usually settle down into something that's a metric-based care contract instead of something that's paid on outcomes just to make everybody happy. And that kind of change is not going to cut it, Todd. You need to come up with a firm assertion that this change is going to happen probably sooner than you think, and to divert resources to a strategic planning group to determine how you're going to make changes. My best recommendation is to create an incubator of folks that are interested in this and make it exclusively a value-based care type of organization and start learning lessons from it, because that's the only way that you develop high-performing systems is by learning the lessons.
Please create an accelerator and not an incubator, because incubators are where startups go to die generally.
There you go. Thank you for that terminology.
Yeah.
So, in fact, even better than an accelerator would be a venture builder, venture
right.
studio.
You really need to take the venture capital, you really have to take the entrepreneurship mindset. You really have to do that and apply that to a little carve out in your organization.
So there you go. There's the course right there, a venture studio.
Well, and fortunately, you're both involved with Seed, and we appreciate what we're doing there. Um, and Venture Studio, future health tech and insure tech, and there's a lot to talk about there. As a healthcare leader and what you've kind of gone through, who's shaped your view of reform? Was it just the environment, or did you have anybody that inspired you kind of adapt to it?
Most of my inspirations have come from thinkers outside of healthcare because there's no innovation in healthcare delivery thought inside the system. And that was true back in the day, and it's still true to some extent now. And so I'm sure that I could find those innovators today, but I tend to get it from outside. I mean, everything from the popular folks like Scott Adams to other folks who specialize in systems analysis. But Todd, the biggest motivator for me was looking at my financials and looking at the contract and thinking, blank. If I don't succeed in this, I'm going to have to declare bankruptcy. And for business folks, bankruptcy is just a fresh start. For folks with professional license, it follows you around for the rest of your career, and it really hampers you. And bloody hell, what did I get myself into? And so I had to get off my butt, and I had to learn about how to do it, and I had to make the changes necessary. It was uncomfortable, it was time consuming, and it was not happy. But that's the only way that you have to learn it. And I fear that that's the only way our delivery system is going to learn it too.
Well, you just described the entrepreneurial journey pretty perfectly.
Yeah. So 2 more questions real quick, and then we'll kind of bring it home here. A personal biohack or preventative care strategy that you use yourself, what would that be?
So right now, my technology of choice are peptides, which I think are really under-researched, underappreciated, and are going to have a powerful impact. The most effective intervention that I'm doing right now is heavy weightlifting, is weightlifting for power. I personally use the Starting Strength program. In fact, I'm going to brag, I just deadlifted 327 and a half pounds 3 times yesterday. So,
Let's go.
I'm pretty impressed with that. Yeah, I put that on the internet, and you can guess what the responses are. It's all some form of "you'll shoot your eye out, kid." And so and many of them are from physicians, and that mindset is gotta change. Okay.
Got to.
I got a lot of things wrong with me, but sarcopenia is not one of them. So that's the most effective intervention I'm doing right now, but the most intriguing one are peptides. And I am very interested in seeing how that plays out.
We entirely agree. We talk about it all the time on this podcast. And peptides are a journey, and there's still a lot to learn about what's being used, but a lot of them have been out there in the news that people talk about every day, right? GLP-1's a peptide, and there's a lot to that. Last question, who should we have on this podcast next? Anybody you recommend?
That is an excellent question. There are so many folks that I could think about, but I would consider somebody who has expertise in system analysis that's outside the health system to provide that perspective, because many of the folks that are watching this come from that mindset as well. I would love to see both of you bounce off of Scott Adams if he ever would agree to be on because of his expertise in persuasion and influence. Because the only way to succeed in value-based care is to move someone from one condition to another. That's a human being. Human beings respond to changes in incentives. They respond to changes in environment. The only way to make them, to promote those changes is through the science of influence persuasion, something that we're very good at as a species. We know how to push fast food and whatnot. The question is applying that to pushing healthy interventions. So I would love to see how a person who has expertise in that, Bob Cialdini would be another excellent guest, and how it applies to the technologies that Seed is looking at in healthcare. Because in the end, it's a marketing problem. It's a story to convince someone to make changes. And that is an underappreciated portion of what's going to happen to succeed. If there's one thing, as we were talking about for primary care physicians, if a primary care physician has not taken the Dale Carnegie course, then you just need to take it right now.
How to Win Friends and Influence People. I took it when I was 23. Yeah, it's great.
Absolutely. You need to take it right now. use your CME money, and you will find yourself in a better position than 99% of your peers.
I'd have to say that's true. And today you could just read Jefferson Fisher's book and watch his podcast. It's arguably better. I would add one thing to that statement about what influences people, because incentives don't actually influence people all that much. They're remarkably poor. Environment, also remarkably poor. Context is almost decisive.
Expand on that.
So if you create a context within which you want something to emerge, it is so much more likely to happen. And context is that combination of environment and perception, managed perception. So if you go to an AA meeting, for instance, there is a context there within which some positive things are likely to happen because they set up that context. Whether you like AA or not, it's old technology, whatever. There's definitely outcomes based on being in that context. It's the same thing, if you go to a church, there's a contextual cues everywhere to have you behave a certain way. And most people will not behave contra to that way when they go into a church, even if they're not religious. Context is very powerful, and we spend very little time designing the context within which we want a property to emerge.
So the assertion is that even if you, say, create a community that's walkable and has access to healthy foods and all the healthy interventions, you need a social construct within that space in order to actually realize the benefits of that particular intervention.
Absolutely. You need social cues that are carefully constructed so that you understand the context that you're walking into, and then you tend to behave accordingly. It's not a hard power thing, it's an influence thing. It's just that when you create a context, you can get emergent phenomena. And a lot of the things we want are emergent phenomena. Education is not emergent phenomena. Learning is emergent phenomena. And you've been in classes where the context was set perfectly well and you learned. And it was great. It might have been uncomfortable, whatever. You learned. And then you've been to other classes where the person is a didact and you just hated them. And that's because they failed to create a context for learning to emerge.
Who do you follow, or give me an example of someone to follow or look at that expands on this concept?
There's a wonderful guy called Peter Block who wrote a book called Community, which is excellent. You can study scale-free networks. So, the tipping point and the updated tipping point give you an idea of scale-free networks, because a scale-free network has to have a replicable context for it to work. And I created with Coder Dojo a scale-free network where people we created this rich learning context and kids learned how to code, which is a hard thing to do. And we made it very replicable. And we got to 127 physical locations in 27 countries without opening a bank account. That's how powerful the context was.
Awesome. Thank you very much for that resource.
Welcome. Thank you.
Sir,
You've been an amazing guest.
Yeah, it's been great to have you. And I just want to thank you, Tom, for your time, your commitment to Seed, what we're doing, your knowledge. And I really am thankful for both you and Bill. Quick opportunity. Can you tell us how to follow you, how people should get in touch with you if it's a clinician that needs help, or a risk-based model, or a health system that actually wants to double click on any of these topics? How would we reach out to you?
Come to TomDavisConsulting.com. I've created a free value-based care success community. I'm putting all of my years of consulting and practical expertise on there for free, because as a physician, I can't really keep it to myself for money anymore. And there's ways to contact me through there. I also have tools that I have vetted as best of breed to solve the small number of very challenging problems for anybody who makes the pivot from fee-for-service to value-based care. So come on, everything that I know I'm putting on there, and enjoy it for free.
We'll put all that in the show notes and make sure that everybody gets access to it. And really, thank you again. And we really appreciate having you on, and we'll probably do it again sometime in the near future. For the guests, please subscribe to Killer Cure. We have upcoming guests like a systems analysis person, Stephen Ibaraki, who's deep into tech. I think, Tom, you might actually have predicted he was going to come on based on what you recommended. So we're looking forward to it. And thanks again for joining us.
It's been a pleasure. Thank you very much.
Thank you.